let me take the privilege to welcome Dr. Raju Giraddi garu. Dr. Raju Giraddi garu is a consultant in Bittadur Super Specialty Hospital, Raichur. Most of his interested areas are pelvic imaging and fetal medicine. On the behalf of everyone, I would like to invite you, sir, to present your presentation on ultrasound in endometriosis, tips and tricks. Sir, please.
Namaste, very good morning to one and all. I thank Colonel OBGY Society and especially Radha ma'am for giving me this wonderful opportunity. It's a great honor being among the stalwarts and my mentors, especially one of the pioneers, I feel, and she's so inspirational. That is Dr. Madhavi ma'am. Thank you, my friends, for inviting me to Kurnool. It's been a pleasure here. So my work is more of basic practical thing. I work under Dr. Jayaprakash Patil sir, who is an endoscopic surgeon in Raichur. So most of my learning in ultrasound is actually retrospective. So I would like to bring out a clinical situation here. I know many of you are gynecologists here. So some cases you depend on a other surgeon, like an endoscopic surgeon, for your cases that you call upon. I would like to bring out a conversation here. Can you play the audio, please?
Hello, Dr. Sarah.
Hi, Dr. Shruti.
Is this the right time to talk to you now?
Yeah, I'm free now. Say, Shruti.
Yeah, actually, we have posted a case tomorrow. It's a case of primary infertility, married life of 7 years, with ultrasound suggestive of left hemorrhagic cyst. So we have posted it for hysterolaparoscopy. Are you free to come tomorrow and operate, ma'am?
Tomorrow morning around 7:30 will take. I have cases after 9.
Yeah, sure. You can just come and operate at 7:30. We'll fix the time, ma'am.
Yes, we'll fix the time. Thank you.
Thank you so much.
I hope this is one of the common situations that we have among gynecologists, that we depend for somebody to come and operate at our center. And I'm thanks to my colleagues, that is Shruti and Shezrin, have done the audio. This actually goes to my boss, that is Jayaprakash Patil sir. Somebody will call and tell that you have a case of primary infertility, please come and do the diagnostic hysterolaparoscopy. And when my sir goes, and this is what he sees for the same case inside. You are able to see in the laparoscopic view, endoscopic view, it's not actually a simple case. You are seeing a frozen pelvis. The POD has got obliterated with the dense bowel adhesions, and actually it was not the hemorrhagic cyst. It is an endometrioma here. So it's a case of, I hope many would have encountered this situation by yourself in your clinical practice. So my important point take over, what went wrong here? Was the preoperative imaging was not appropriate or not thorough enough to say that it was a case of endometriosis? How can we miss these cases? So we'll look into those basic approaches, how we can not go wrong, and like the mimickers of endometriomas. I will give you another example for especially for the gynecologist here. You have taken a case for endoscopy and you are doing it for primary infertility. You are assessing the tubes, the uterus, the ovaries here. They appear normal. The POD is free. The tubal patency is appearing normal. But you are able to appreciate, though the POD is free, small superficial peritoneal deposits at the level of uterosacrals and all. Still then, a controversial area whether to say, yes, is it a case of deep infiltrating endometriosis in the laparoscopic view, or my imaging is going to help the surgeon to tackle it in a better way. So please remember this case. I'll come back to this case later. So obviously, as sir has told that it is TVS is a must, and almost we all know that why we are using TVS, and this case I'm trying to show you, it's very simple, because already sir has showed you the descriptors in iota, and first lecture was shown by madam also. You are able to describe this lesion. Yes, there are two unilocular cysts on the right ovary and the left ovary. They are closely approaching, got fixed behind the uterus, and the internal echoes are showing ground glass, typical of an endometrioma. I may not describe this because an iota, as what it says, the classical descriptor for a endometrioma goes, it might be unilocular or multilocular with thick wall capsule with poor vascularity and internal echoes showing low internal echoes, that is of a ground glass. This is a classical. Nobody will usually miss these things. So is it what, after looking this, we have to end our reporting, or we have to go more deeper to look at other areas of the pelvis? So I am stressing more on the pelvic imaging with respect to TVS, because if today you are seeing 10 OPDs, very rarely you will find an adolescent having such a problem where you need to depend only on TAS, but definitely 8 or 9 people sometimes in the whole day, you are absolutely able to do TVS for everybody. So that is the most common thing, so I am sticking on to TVS. So if you look, when you try to do a transvaginal sonography, and you are able to appreciate here, this uterus is having an anteversion and a retroflexion here in the upper corpus. This is going to tell me by this organization of this endometrial lining that there is something behind which is trying to pull the upper corpus. It is going to tell me that apart from the focal adenomyoma that you are seeing in the outer part, you are expecting a bowel adhesion there, which is trying to pull the upper corpus. So for that, if I want to move ahead, I will try to stick to the next 2 slides, which will play a very important role for all we who are doing pelvic scans, because this is where this 2016 it was a breakthrough idea consensus came to show that how we have to image and how we have to do the imaging perspective with respect to TVS. One thing I want to tell you, this has really changed the perspective of doing a transvaginal sonography, not because only in endometriosis cases, even for a routine gynec cases where you are looking out for the causative factors for infertility or dysmenorrhea or dyspareunia, you have to do a systemic scan. This is what it has showed, how to do a systemic scan. One important thing I want to tell you, this is a free access paper here. You can scan here and you can get that in your camera itself. Whenever you see a logo like this, it is telling this paper is having some abstracts or some supportive information. So always go and watch the videos there. If you download the paper, you will not be able to watch the videos. When you have the logos like this, you go and watch the videos also. These are freely available. For the next 2 slides, I am going to show you how a systemic scan has to be done so that we are not going to miss the pelvic pathologies even in minute details. So this paper gave us about how to do the sliding sign. Of course, we are looking at the uterus and the ovaries that forms the middle compartment. They are asking us to look into the anterior compartment as well for look the bladder and the ureter. And posterior compartment, of course, we have to be thorough enough to look for the POD obliteration, the uterosacrals, the rectum and the rectosigmoid areas. So yes, they told in 4-step manner, you can follow in any other way. It need not be in the same fashion. But what I want to stress here, like in fetal medicine, you have soft markers. You also have soft markers in our imaging with respect to endometriosis, where you look for the site-specific tenderness, what sir was enlightening on that, and also on the ovarian mobility, what we look for the sliding signs. These 2 play a very important role because I call TVS as a dynamic scan. It's not just static scan. You may have to use both the hands and you have to do those sliding signs such that you are going to also look for the site-specific tendernesses in such cases. So I'll go with my basic scan, these 2 slides. I was repeatedly telling this, but now these are the 2 slides which I want to stress upon. If you start doing this every day, every patient now and then, definitely you will also pick up some deep infiltrating endometriosis in your coming up cases. Look here, I have kept my transvaginal probe at the introitus. I have kept my sector width at almost 180 degrees so that I want to see the uterus in its entirety. And my orientation, this will change the orientation with respect to what Gayatri madam had shown. Her logo was this side. My logo is on this side. I do it as if I do for a fetal medicine scan. This is the bladder here, and this is how I'm going to orient. So that my future slides, whatever I'm going to play you will get oriented to what my imagings are. So I introduce my probe slowly from the introitus. This is the bladder here. You can appreciate the urethra. And as I slowly go and hit the anterior fornix, I'm able to see the upper lip of the cervix, the posterior lip of the cervix. Now I am taking enough depth so that I want to include the uterus covering almost the 80% of the screen or 75%. I play with the focal zone so that the focal zone is along the endometrial lining. Now I come back and see at the cervix and follow the endocervical lining to the endometrial lining. So at the same time, I'm looking at the serosal borders, the myometrial echoes, and how the endometrial echo is standing out. And now I start taking my sagittal sweeps. I start taking towards the right side first, then I come back to the middle, then I go towards the left side. At the same time, I keep looking out any other pathologies that are being or any space occupying lesion is there which is popping up. So now after I have done my sagittal sweep, I will go for the transverse sweep. For me, I will do it anti-clockwise because my logo is on this side, and this side will correspond to the right side of the patient, and this side will correspond to the left side of the patient. So in my anti-clockwise, I again start looking into the whole of the uterus, that is the middle compartment of the uterus. I go towards the cervix. You are able to appreciate some Nabatean cysts there. Then I come back slowly, and I keep looking at the endometrial lining. If there is any splaying of this endometrial lining or any other pathology which are popping up, I go up till the fundus till I lose the endometrial lining and the serosal layer. So this is how a basic TVS has to begin and done. Sometimes you may have difficulties, like the position of the uterus may be different, as we have seen in the first lecture. Now I'll go to the adnexa. In my transverse sweep, I go and follow the bands, the adnexal bands, and I look for the ovary. How do I how do I identify the ovary? Usually they will have follicles, and the ovary has to be seen in one sweep, either from up down or from side to side. So apart from this is the right ovary. Then I go. This is the uterus here. I go in the same fashion to the left side. I see the left ovary. So left ovary again. I analyze that what is there inside this left ovary. How many number of follicles and all those things, that is out of my context here, but still now I come back and see the uterus. Now is the important step that we need to follow in almost all pelvic scans, that is look for the sliding signs. I try to place my probe in between the uterus and the ovary and try to see how they are relating themselves to each other and how they are moving in different axial planes with my push. So you may have to use your left hand if your right hand scan, if you are doing right by right hand, so that when the ovary is not in visibility, you have to push it. So you are able to appreciate that this is called as positive sliding sign, where they are moving in two different axial planes. I reduce my, I increase my depth, so that now I am putting my probe in the anterior fornix and giving a push in the anterior fornix. I am trying to see how it is related to the posterior compartment, that is the bowel. You are able to appreciate the bowel is moving in different direction in the uterus. Now in the anterior compartment, this is the vesicovaginal fold. You are able to appreciate the sliding sign which are positive. This is what, without this you cannot complete a pelvic scan. Next is I place my probe in the posterior fornix. This is to look for the uterosacrals, where I place my probe in the posterior fornix. As I closely approach the peritoneal fold of the pouch of Douglas, I take my probe onto the right side to see the right uterosacral by turning it clockwise around 30 degrees, but not more than 40 degrees. This is one of the method. I will try to show that. The paper is also there to show that. So I start looking, I come back to the middle, and then I go and trace the left uterosacrals as well. For any infertility patient, this is the basic thing I try to do in each and every case, so that I am not missing any uterosacral nodules also. Maybe I am falling short at the peritoneum, because some areas I cannot really reach with the, that is the limitation that we have in ultrasound. And if I don't find any other pathologies here, I usually don't do the bowel trace. If at all I find some endometriotic pathology, then definitely I have to do the bowel trace also. So now you can appreciate in this case, the ovaries are stuck behind the uterus. This is the uterus, and I'm trying to do the sliding sign. The whole complex is moving as a one thing. They are not sliding against each other. So this is to show that it is a negative sliding sign. So you can appreciate here, as I'm trying to place my probe in the retroverted uterus, this is a retroverted uterus for me, I'm able to see, one second. I'll leave this. Okay. One important thing, as what sir was telling about cystic structures in the pelvis. Any cystic structure in the pelvis has to be compared with the bladder. So I have kept purposely the bladder for demonstration purpose. This is the echo of the bladder, and you are able to appreciate as I go towards the left side, you are able to see two cystic lesions. What do you want to call them now? Are you want to call them a simple serous cyst or with anechogenicity, clear content inside? Or may I need to change my settings to really define what is there inside? So what you can do is, you have to play with your gain settings such that your bladder should be anechoic you have to raise the gain till that. You have to increase the gain till the bladder is maintaining its anechogenicity. And once I keep increasing the gain here, you are able to appreciate this cystic structure is actually an endometrioma. It's not a simple serous cyst. So gain settings does help in defining your other cystic lesions. I was trying to stress upon these things. positive sliding sign where the ovary and the uterus are moving apart each other. Try to do this in all cases. This is an hemorrhagic cyst here. It is moving easily from away from the uterus. When a retroverted uterus in this fashion, you are able to see, I am trying to place my probe in the posterior fornix. This is easily sliding, the bowel is easily sliding, and you are able to appreciate a good amount of fluid there. This they are trying to call it as a triangle sign, but this will tell us that there is free POD, but it doesn't rule out uterosacral nodules. We shall see how to do that. So negative sliding sign is very obvious. We call endometriosis as a medializing disease. The uterus tries to suck the adnexal structures very close to it. You are able to appreciate that this is a case of an endometrioma which is very closely stuck to the uterus. So in the posterior compartment, you are able to see a negative sliding sign. The bowel has got adhered to the posterior compartment. They are not moving against each other, but they are moving along with one probe, moving together. So this is another paper where you can freely access this, how to span your uterosacrals, which is easily available. So this is how we try to do that. Here, once I have done my initial probe movements, I come back and look for the cervix. Once I come and look for this is the cervix here, this is the anterior lip of cervix, this is the posterior lip of cervix, and I try to place my probe in the posterior fornix. I closely approach near the thorax region or when the peritoneal reflection at the POD. I take my probe clockwise so that I want to see the right uterosacral of the patient. So when I do that, this uterosacral nodule uses a hyperechoic structure which stands out linear, and then I come back to the middle. This is on the right side. I come back to the middle and then I go to the left. For the left uterosacral, I have to rotate my probe anti-clockwise, not more than 45 degrees, so that I can be able to appreciate the left uterosacral as well. So when I am trying to do these things, in one of the other cases, definitely in this case, anterior lip of cervix, the posterior lip, and I try to place my probe in the posterior fornix, you are able to appreciate a thickened hyperechoic endometrial, this is the uterosacral, but what is that you are seeing within the uterosacral is getting hampered by an anechoic irregular structure which is filling this uterosacral within the uterosacral and also at the upper borders of the peritoneum. This is a case of endometriotic nodules that you have in the uterosacral. So spanning across the posterior compartment plays a very important role. I showed you this case, though it is having a very good positive sliding sign. You can also appreciate the triangle thing here. That is what they are telling, that its POD is definitely going to be free. But when I look into the uterosacrals, when I trace for the uterosacrals in the same case, you are able to appreciate an endometriotic nodule here onto the right side. So this hypoechoic lesion within the uterosacral is telling me that yes, uterosacrals, as we know in gynec, that the most common site for endometriotic nodules is the uterosacrals. So we need to span across the uterosacrals in almost every case because this patient has severe dyspareunia, and this is what we can actually make out in such cases. Another case to show here, this is a retroverted uterus and I am placing my probe in the posterior fornix. I hit the thorax region, and well at the thorax region you are able to appreciate a well-defined circumscribed lesion, hypoechoic in nature, irregular, and that is an uterosacral nodule. And on the right ovary, I am having a small nodule there, that is the endometriotic nodule, which was very close to the right uterosacral. It's very close to the right uterosacral. As I go towards the left, you are able to appreciate another nodule in the uterosacral. So if I span across the uterosacrals from the right to left, I was able to appreciate there are multiple endometriotic nodules in this region. So this was a left ovary which was appearing normal. When I take the transverse sweep of the uterosacral, you are able to appreciate a hypoechoic nodule on the left uterosacral, at the thorax region, and also on the right. The whole of the endometriotic component is morely affecting the POD region, especially at the uterosacrals. So how is this case looking for us in endoscopy? So you can use 4D application, that is VCI, to make these nodules to stand out better, and you have to always measure them in 3 orthogonal planes to give the measurements. And once you have done that, and in laparoscopy, you are able to see, as we have got it, the right ovary was very closely abutting onto the right uterosacral, and that was associated with a small chocolate cyst within. So we are able to appreciate here the POD, though it is free, but look at the uterosacrals have got puckered and they have got fibrosed. So this is how after the cystectomy and enucleation of this chocolate cyst, we need to go ahead with dealing with the deep infiltrating endometriosis. Now we go to the virgin area of the peritoneum, and once we do that, you are able to appreciate that this deep infiltrating nodules, which are actually taking up all of the uterosacral and the thorax region, has to be excised so that you are going to give a complete surgery and a better outcome for that. So the pain and the post-operative pain and the dyspareunia or whatever complaints they have, definitely the quality of life is going to improve. And it is just not doing fulguration of the superficial endometriosis. If you think they are, sometimes they will be deep infiltrating. You have to get a good mapping. So this case which I showed, I asked you to remember one case where I showed you this. When I place my probe in the posterior fornix at the uterosacral, at the thorax region, you are able to appreciate a hypoechoic nodule. So this was actually an endometriotic nodule deep into the uterosacral region, and it was going almost. So this was the case I showed you. So we saw some superficial peritoneal implants here, but that was not enough. But because our imaging had shown there is a deep infiltrating endometriotic nodule inside, so definitely we have to do a very good excision surgery at this place. So what we went ahead is, based on the mapping, we had to give enough cuts, go into the deeper planes and excise and look for that nodule in the uterosacral or the thorax region. So you're able to appreciate the fibrosed uterosacral part and also the part of peritoneum and posterior to it. Almost we are reaching the dissections of the rectovaginal plate here. So you are able to appreciate the chocolate and material that is coming out of this nodule. So imaging does help us so that you can preoperatively map them and give the surgeon. See, sometimes definitely endoscopy will give a lot of pictures where superficial peritoneal implants of I may not pick up. Maybe even USG fall shots of the MRI, you have to depend on MRI. But sometimes at the rectovaginal area and this uterosacral area, you can definitely make out these nodules. Apart from simplest thing of the endometriomas, the hydrosalpinx, the hematosalpinx and all that can be easily made out. So we always expect our D-scopies to be like this, where you have a normal uterus. This is how a normal uterosacral will stand out. The POD is so totally free. But this case was not like this. So our preoperative mapping does help the surgeon to go further with the plan of action, so that he will definitely change his plan of action. We may have to depend on a better surgeon who does good deep infiltrating endometriotic surgery. I am stressing more on uterosacrals and again, so that we don't want to miss these. So here is a case. It was a case of posterior wall myoma. We have removed the myoma, but the previous imaging was showing me there is a deep infiltrating endometriotic nodule in the rectovaginal plate. So though we could see the puckering of and the thickening of the uterosacrals, we need to go now from the virgin area. Though we cannot see all those things in laparoscopy, because our imaging mapping has given us there is a deep infiltrating nodule. So we went ahead with the advancement of the surgery into the rectovaginal area, and you are able to appreciate that big nodule being excised out. So you can definitely help in these ways. Start doing your TVS in a systemic manner so that you are going to look into all the compartments. Definitely look at the PODs a lot better. Uterosacrals are the most common areas of your deep infiltrating endometriosis. So this is how now I want to show, in case of a normal retroverted uterus, how easy you can definitely look for the endometrium. This is the uterosacral. When I keep my probe in the posterior fornix and when I reach the POD here you can take the reflection. This is the right uterosacral. When I take my probe towards the right clockwise direction angulation, then I come back to the middle and look for the left uterosacral. The same fashion can be in a retroverted uterus. So this is what I want to stress upon of doing a systemic transvaginal sonography, so that you are able to appreciate these nodules. So now, once I have got a uterosacral and an endometrioma, now it is time for me to look for the bowel nodule. From the introitus, these are the external anus sphincters. From the anus, I place my probe in the posterior wall of the vagina. I am trying to trace this bowel. You are able to appreciate this bowel trace here. This has an outer serosal lining and a hypoechoic line, which stands out to be the muscularis layer. I am able to slowly advance the probe slowly. I am in the rectovaginal area now, in the rectovaginal plate. Then I go towards the POD. Then up to the farthest extent till ever where I can move my probe, I am able to go into the rectosigmoid area, and I am able to see that this bowel in its continuity, it's appearing normal for me. So if I want to make a note of all the layers of here, this is the serosa, this is going to be the muscularis propria, which has another hyperechoic line or a band like thing which differentiate into outer longitudinal and inner circular layers of the muscularis propria. Then you have the mucosa and the submucosa. So usually the endometriotic nodule will always involve the anterior part of the bowel, and you need to keep tracing these things, keep doing it in all cases. Sometimes you'll definitely get a lesion. For example, in this case, I'm started tracing from the anus region. I'm looking into the probe in the anterior layer of this bowel. As I go slowly, as I pass the rectovaginal plate, and I take some movements so that if I'm losing the continuity, I have to go back and come forward, like as if you do in hysteroscope. When you lose, you go back, then you come slowly and get the continuity, because sometimes the sigmoid will curve towards the left side, and this is what you are able to see. This muscularis layer, as I advance towards the thorax region at the level of internal os, there is a nodule which is appearing. There is discontinuity that you are able to appreciate. So you have a uterosacral nodule as well here, and a bowel nodule also. So any bowel nodule, these are described as various, like moose antler sign, Indian red headdress sign and all. But yeah, definitely you have to take in 3 orthogonal planes and measure them, how large they are, so that the surgeon can be given a definitive approach saying that whether he has to go for shaving or whether he has to go for segmental resection as well. So yet another case to show these bowel nodules, how they appear. The paper is showing us various signs and various morphological diagrammatic pictures that you have there of how it appears. So this is going to tell us that our scan should be systemic, and a thorough TVS has to be done, including the uterosacrals and the bowels, to look for such lesions. So yes, this lady underwent hysterectomy for severe dysmenorrhea. It was a case of adenomyosis, but still she has not relieved of her symptoms of pain abdomen and especially dysphagia. Though we have removed the uterus, but we have not removed the endometriotic pathology as a whole. What is that I am trying to see here? This is the vault of the uterus, and when I start tracing the bowel, you are able to appreciate there is still a bowel nodule which has been left. So yes, you have a better pre-planning of the surgery, so that your counseling will be different, and also try to remove the pathology as a whole. Just not removing the uterus will serve the purpose in majority of the cases when it is a deep infiltrating endometriosis. So in this case, I'm sorry I missed the TVS volume here, but in transabdominal imaging, you are able to appreciate an hypoechoic nodule well within the bladder at the level of the bladder base. You are able to appreciate an endometriotic nodule involving the anterior compartment. So when you have given this, you will go ahead with the cystoscope first, then we'll try to locate that and how large is the bladder and how far it is from the ureteric orifices. Based on that, now you will take a decision how to excise this. So you may have to stent the ureteric orifices. Then in this case, because it was a large bladder at the level of the superior border above from the ureteric orifices, we went ahead by doing a transperitoneal approach. We literally did a cystotomy, then we had to remove and excise that whole endometriotic nodule, and then we had to suture back the bladder. So this is how. Yes, definitely when you have such a case, you have to always look for the ureters, and you have to also look for the kidneys. So I have done an imaging. This is how I write, but definitely nobody will like to read such things. My boss always looks at the diagrams. So place yourself in diagrams and try to map those in diagrams based on the, like I usually put the sagittal view showing the relationship of especially the posterior compartment where you have the pathology is more, and the posterior compartment I give the posterior aspect view, because anterior aspect I may have limitations in USG, but definitely also the involvement of deep infiltrating is less on the anterior compartment. When you are given this, sir will try to decide, okay, what next I have to do. Some of us can follow the various classifications like the ASRM or what we have the recent the NZN classification. So this is going to give us a better correlation. So NZN is trying to tell us something on peritoneum, the ovary and the tube, and also for deep infiltrating they have named it as ABC, where A stands for it will look into the areas of vagina, the rectovaginal space, B for the cardinal or the the ligaments, and C for the rectum. And you have something for F, like no, you have for adenomyosis, bladder, intestine, and also it will go up to other areas of ureters as well, also diaphragm and lung. And now these are limitations for most of us in USG. Definitely you have to depend on MRI sometimes. Yes, peritoneum is one area. USG cannot pick all the superficial nodules. I may fall short. So whatever modality of imaging you are doing, for example, if you are doing ultrasound, you can use NGN-U. If you are doing MRI, you can do it M. Then if you want to comprehend with the surgery, because most of the time we will be falling short of the exact pathology that was there inside. So post surgery on intraoperative also, you can definitely make a better classification how extent was the peritoneal involvement. Sometimes if you don't find it in your USG, you have to keep it as X. So based on that, then based on the lesions that the measurements, you have to keep it as P1, P2, and based on the values that they have given, less than 3 to 7 and all. So you put the left ovary first and the right ovary on this side, and if the ovary is not seen or missing, you have to put it as M. So you will get these classifications very easily to read because they are freely accessible. Place yourself in diagrams such that the surgeon will come to know what exactly I am going to expect in the endoscopy. So yes, he will try to plan accordingly. That for example, the madam told that it was a case of hemorrhagic cyst. So she planned it so early before she was going to OPD. So she thought it is a case of simple hemorrhagic cyst. So she planned it that I will do it in half an hour. So that should not happen. You should not have intra-operative surprises. So your imaging should be such that madam would have planned this surgery at 6 o'clock in the morning with better armamentariums. Before that, the patient would have given a lot of better counseling of the outcomes that are going to happen because of the endometriosis. Yes, I wanted to stress upon looking at the ureters here. Large ureter is getting obstructed here by the large nodule. Definitely, if you are not able to trace the ureters properly, you have to definitely look at the kidneys to rule out hydronephrosis, because ureteric parametrial involvement of the, and if it is involving the ureters, it's going to be a tougher job. So in this case, don't always expect that I'm seeing a fibroid here and I'm happy. No. You look here, you have an endometrioma in the same case. You have a fibroid, a large fibroid in the right posterior compartment, and an endometrioma on the right, and another lesion in the serosal, well within the serosal borders of the uterus, which is showing some low intensity echoes within that circumscribed lesion. And also you are able to appreciate a bowel nodule which is closely abutting onto that circumscribed lesion at the level of fundus. So this entity is having almost everything. It has a fibroid, it has an endometrioma, it has a bowel nodule, and also the lesion that I was describing was acum. So this case, you are able to appreciate intraoperatively the bowel was closely abutting and got attached with the small serosal nodule there at the level of the acum, and this is the acum lesion on the right fundus aspect. You are able to see the the bowel adhesions at that aspect. And once we have released that, we went ahead with myomectomy. Once we have removed the fibroid, and once we have removed the fibroid also, we do extensive surgeries to all get back the anatomy proper. So this is after removal of the fibroid, and this is the lesion that we tried to show you. This is a case of acum also. In the same case, a chocolate kind of material, a chocolate cyst within the uterus, not in the ovary. So this is how a deep infiltrating endometriosis surgery has to be. So pre-planning should be so good enough. Your basic TVS probe movements will help you to tackle and try to get in a lot of information, especially the POD. Don't miss the uterosacrals. And once you have mapped that, definitely the surgeon, you will depend now whether you want to call me or you want to call my boss for that case, because the surgeon will be different now. For example, if you want to call, you can't depend on me for this surgery, though I do simple basic surgeries. You will ask Dr. Jayaprakash Patil, or maybe you will refer this case to Vimi madam. So these are the importance of doing systemic transvaginal scans. I thank my mentor, my boss, Dr. Jayaprakash Patil sir, because of him, what I'm trying to do always is really great work and really inspiring. Thank you so much.
Thank you very much, sir. I guess with this talk, we will change the outlook of and the way we scan